Why aren't we set up for integrated care? I am Matthew Hart from Longwoods. And maybe this is a little bit too basic, but I have group chats set up with my sports teams, my family, my friends, work, and more. Why is it so difficult for my entire care team to coordinate? If I go to the hospital, will they know what I've been working on with my primary care team? Does my primary care team know what I've been working on with my dentist? What are some of the issues we're facing moving forward with integrated care? Let's find out. The recording of this episode was fun. I know that you'll enjoy it, so I'm not going to delay anymore. Leading today's discussion will be Dale McMurchy and Stephen Lewis. I'll let Dale introduce our guest. Enjoy.
Thanks, Matt. Today, Stephen and I are joined by Walter Wodchis, with whom I worked in the late 90s and have crossed paths with several times since. Walter has a number of professional roles that relate to integration. He is the professor at the Institute of Health Policy Management and Evaluation at the University of Toronto, where he led the Health System Performance Network for nearly 2 decades. He is co-lead of the North American Centre on Integrated Care and the International Foundation for Integrated Care Canada. He is the research chair in implementation and evaluation at the Institute for Better Health, part of Trillium Health Partners. Walter is best known for his research on populations with the greatest need for health services and on integrated care models. So let's get started. Walter, many Canadians, especially those you study with complex healthcare needs, have a story to tell about the negative effects they've experienced from our fragmented health system. Why are so many people either falling through the cracks or waiting too long for services?
Thanks, Dale. It's a real pleasure to be here. The first thing I want to say is healthcare providers and policymakers that are overseeing are all trying to do a really good job at what they do. And so as a healthcare provider encounters a patient, they'll try and address their needs and see them on to a better journey in health. The challenges that we have are that the healthcare providers and organizations are working on their own. They are paid separately, they are funded, they manage patients in the way that they present to them through their front doors and then watch them go as they leave. And we do not have very good systems to support the inter-provider networks, communication, relationships. And so when patients are moving between healthcare providers, it becomes a real problem for them to establish continuity of care and have that care be coordinated. This is a minor issue if there are 2 providers, but it becomes a very significant issue for people who have multiple conditions and multiple healthcare needs and maybe seeing 6, 7 different providers over the course of their treatment, which for many people is an ongoing issue. So it's these gaps between healthcare providers that cause the greatest concerns for people.
So you've been focusing on the integration of individual patient care, so across perhaps an acute episode of care or ongoing care. But there's also models that we've implemented in Canada and across the world that look at a larger patient population and patients within a geographic area. Is there anything different about those types of models, or are they just an expansion of the type of thing you're talking about?
Okay, so I started this by thinking about individual patient care, because I think that actually is the way we need to think about all of the supports and infrastructures and approaches, is that we are driving to ensure that patients have an optimal experience and have optimal outcomes. So you have introduced one of the ways of actually achieving that, and that would be through population health and possibly integrated health systems that then address the healthcare needs of an entire population. To do population health management, you need to do a couple of things. One is you have to have an assessment of the health of the population. So you could have an entire population living in a geographic area or somehow attributed to a health system through an enrollment model or otherwise. And then with those health assessments, you need to understand what the patient's needs are. And what we're going to find is that actually a large proportion of any given population, if it's a representative population, are going to be fully healthy and will need very, very little health care. They're totally fine. Then you have some people who maybe have some minor chronic issues, be it a bit of arthritis or, some hypertension, that's high blood pressure. And they are also, with very few encounters, going to be able to manage their health just fine, rarely experience, massive delays or gaps in coordination of their care. But we start getting up to people who have multiple chronic conditions, and also even into areas where we have frail older populations, and they may be experiencing some gaps in mental acuity as well as 3 or 4 chronic conditions, the treatment of which becomes very complex. And so having a population health model allows us to think about how we organize care differently for the different populations, subpopulations. And that's really essential, because what I'm going to say here is that we're talking about a problem that doesn't infect the entire population, but it very much affects a small proportion of the population. And that, say 5% of the population with really high needs, that is where 2/3 of our entire healthcare expenditure goes. So our healthcare is actually managing primarily the needs of this smaller population of people who have acute and chronic ongoing needs. And that population segmentation and population health management approach allows us to think about different approaches to care for different subsets of the population.
There's been several attempts to integrate care in Canada. Why have so few of these actually managed to truly integrate services?
I'll say there have been some examples that have succeeded, and maybe let's come back to those a little bit more after. Mostly models that have failed have been because they were pilot studies, so they were actually time limited. Decisions were not very clearly stated at the outset of what would make a decision to go forward. It's more about, oh, that sounds like a great idea. Let's try it. Oh, that's working, or that's not working fully. Let's abandon that and go do something different. That's called pilotitis. It's a little illness we have of just doing pilots and not actually building for sustainable models. So first off, thinking about things is just, we're going to have project funding for this small project to try it out for 6 months or a year, and then we're going to abandon it. There's no sustainability plan. So that's a first problem, is not building for sustainability. The second problem we have is many of those programs do not reach their intended goals because they really didn't take enough time to think about the problem that they were trying to solve for. And they didn't really think about what all the services needed to be included in order to provide optimal care. So that, people with heart failure and, 2 or 3 other conditions are put into a heart failure program. And it's an integrated model of care for people with heart failure. But then they actually only have medical providers, and they might only have cardiologists involved in that model. And they've forgotten that these people have many other conditions and issues to deal with. And they've also forgotten that these people may also have what we call social determinants of health. So they may have difficulty with income, having enough to pay their bills, have good food, nutrition, buy a membership at the gym. They may have some housing instability, which makes them very anxious and more difficult to follow. They may have mental health problems. Very often we have medical interventions that are not really considering the psychosocial needs of people. And so these programs haven't been comprehensive enough in their thinking, and therefore they fail to meet some external, validation, like fewer hospitalizations or fewer visits to an emergency department. And then they're deemed to be failure, as opposed to, wait a minute, which part of the problem did we miss? Let's address that need as well as part of this program, and then move forward. So more of a design approach to doing things as opposed to a one and done.
So yes, people fall in the cracks, but is it the structure that's the problem, or is it something else? For example, I'm a hospital patient. I have those psychosocial needs, some need for community services. There's a social worker. The social worker acts as kind of a case navigator. It works sometimes and it doesn't work other times. I mean, the part that the patient needs and cares about is coordination of services, as you said earlier. When you think about either success or failure, are there structures that make it impossible to succeed? And are there structures that make it much more likely to succeed? Or are they kind of irrelevant? If people take the coordination needs seriously.
That's an excellent point, Stephen. And so there are institutional structural barriers that sometimes those pilots are trying to get around. And, we have policy workarounds, or how people actually try and work around the rules in order to deliver these programs. There's always probably rules that need to be broken, frankly, to be successful in integrated care. People have very strict rules around what they can and cannot do in the healthcare system. Hospitals, for example, by and large, are only providing care from the time somebody enters the doors until they leave the doors. So they might do a follow-up call to see if people got back home okay, but really they are not, in general, able to provide services beyond their walls, and they have communication barriers. They don't even actually know all of the resources and how they should be well coordinated in the community, and they can't do it themselves. Primary care physicians, unless they have a license to act within the hospital, we don't have them coming into the hospitals to follow patients anymore, like they used to in olden days, and have that continuity of care over time.
Why do we have to break rules to do the right thing?
Well, I think that we're opening a really important opportunity here to think about what are the rules, the barriers that make sense, and which ones do not. And any of the areas where we've tried to have integrated care models, there's always policy barriers. And I'll say where we've been more successful, the policymakers find ways to change the rules so that providers can do those things. So as an example, we have in Ontario some examples that we had in something called an integrated funding models, which was an integrated pathway from hospital to home. Hospitals were able to apply to become designated home care providers, as an example, and then they were authorized to purchase home care in the community. And so we changed the rules. There are ways. Now, why does that not happen at scale? So fear is the first thing. So let's just think about how I'm going to say two ways that fear causes immobility in the healthcare system. There are bureaucrats who are afraid that they might make a mistake and get something wrong. And the worst thing that they want is to make a mistake. And then we have politicians who really don't want to be seen on the front pages because someone didn't get a home care service because they were trying out a new approach to doing things and a mistake got made. So people say right now things are really bad. I could have used a more profane expression there. If we try something new, we might have something even worse, or we might have something unusual happen that causes concerns, might get some people some media attention that they really don't want. So those are all fear-based responses. And the last bit is there's a little bit of protectionism too. So if, for example, we do need people to be boundary spanners, and we do need people to change roles and share similar roles. And people get to be very concerned that their organization will not continue to receive the same funding level if another organization is allowed to come in and do some of that work. So just allowing that, gets people's quite anxious that there was one hospital CEO used to call it circling the wagons. Once we start actually thinking about change, people start circling the wagons around their budgets, their orientations, and that actually creates significant barriers to actually collaborating, sharing resources, which is fundamental to providing more integrated models of care.
In very few of these models, is there actually truly full integration? There's always carve-outs and exclusions, often related to, for example, payment for physicians, maybe a silo part of the funding model. So often the budget and the accountability are not one and the same.
When you talk about accountability, I'm going to put it under to achieve optimal integrated care, we need financial and clinical accountability in one shared group. It needs to be accountable to all of the organizations that are participating, and it has to be a shared accountability. We'll have like a shared budget that, and I'll give you an example called the Program for All-Inclusive Care for the Elderly, or a PACE program in the United States. It was originally built out of San Francisco in a community, but then spread across the United States to 25, 35, maybe they're up to even like 40 or more programs. And they take care of the entire population of elderly people. They have full clinical and fiscal accountability. They've got a capitation budget, and they pay for all healthcare services within that budget. They have accountability for the health and the financial outcomes.
And that's all in. That's
all
physicians,
in.
That's specialists, that's all in. They're accountable to their outcomes.
Some, particularly if somebody needs a kidney transplant or something like that, that might be like paid for outside because it's just a very, very high cost, unique circumstance where that would be, almost a reinsurance or carve out, but only on very, very few, very high cost things like organ transplants might be not covered under that program. And many of the accountable care organizations in the United States then also have these same, at a macro level, they're quite large. I mean, they're millions and millions, tens of millions of people in those health maintenance organizations and accountable care organizations where they, at scale, have clinical and financial accountability. And then they need to work with all of the many healthcare providers across the entire healthcare system to better organize and coordinate care. And, they have some successful models, and, we'll talk about some of those in hopefully in a few minutes.
So why in Canada can't we get past fear and protectionism?
Fear is a tremendous motivator. Quite frankly, cannot explain another reason why, for example, we haven't looked to have strong negotiations with physicians to bring them more within the fold of the healthcare system. There's clinical autonomy without having, operational autonomy. People have felt that the risks are too high in terms of political re-election.
But let's just take a very common and very serious problem in Canada, which is people continuing to stay in acute care hospitals who are no longer acutely ill, the alternate level of care days. There's recent data from Alberta that the hospitals are operating at over 100% capacity. So the notorious hallway medicine really lives. And yet in some of those hospitals, the percentage of beds that are occupied by people who don't need to be there is 20% typically, and in one case, it was 40% a few months ago. Seems to be an obvious solution of integration would be, why don't you just combine the acute and the post-acute budgets? So that strikes me, that's a fairly risk-free, in some ways logically trivial way to solve a particular problem. But also, it avoids, if you can get the alternate level of care days down to near zero, it will defer the need for building new hospitals. So, Walter, in a nutshell, why wouldn't you do that?
We have started to do that. Why we have not finished doing that is more of an open question. So I explained in Ontario, for example, the issue with the transitional care programs through the integrated funding model, where they did create combined budgets for acute and post-acute care, up to 60 days post-acute, and then people would transition to other types of home care. The province took those findings, and what we had said at the time, that we were highly reliably successful, where we had this model for planned surgical procedures. It was cardiac was the example in the time, but the next most common one, or actually even more common, is hip and knee replacements. And so Ontario actually has now bundled funding for acute and post-acute care for hip and knee replacements. When you go in, the hospital is responsible for your acute and any post-acute home care that you might need and immediate rehabilitation within that single bundle, including inpatient rehabilitation if they need it. And we've actually found that, when they put in that model, hospitals shortened their own acute length of stay, and they provided more home-based rehabilitation services. So it was actually led to more efficiency. We think that should, we meaning like our research groups, think that should actually extend to all elective surgery in Ontario and across Canada. Why that paused, I cannot explain. I possibly, it rolled out just before COVID, and then COVID came, so all, people kind of got very distracted, and they haven't come back to that. But there's no reason that shouldn't be paid for under bundled funding, acute and post-acute care. I will say that some of the home care organizations, that's going to require new people, possibly, or new bids, because the hospitals themselves aren't going to hire a new workforce. Mostly they contract to home care agencies for that work, but that can lead to shifts in the market share for some of those home care organizations, who are often more concerned about preserving market share than getting, more optimal care models in place for clients. And then, Ontario also has a large home care agency that also has a bit of an interest in preserving status quo in many times. I think there's now leadership that might lead to some new models of home care, but that entrenchment and fear of market share, I I think, has stalled that program. But there isn't, I think, all acute, post-acute, that bundle you explained, that should absolutely be in place. And getting it up the policy chain to have the decisions made is important. There may be one, just thing in the back of my head is that home care is not part of the Canada Health Act. It's not a guaranteed insured service. And so the hospital services are, and by building that into the hospital services, we may be making a structural commitment to provide home care as part of healthcare. And people might be a little bit reluctant to do that because it takes on, a future obligation. I don't think that's a significant reason, but it could be that adding more services into what is already a very large healthcare budget might be a little bit of a disincentive.
Why wouldn't you do it for medical? Because there's a lot of people awaiting long-term residential care who can sit in a hospital for 2 months. If you're a government and you want the services to be as efficient as possible, create the conditions where you can be more efficient. I guess the dilemma is it may be cheaper to allow some inefficiency because of 20% of my beds are occupied by people just sitting there. They're not getting much service. They're actually pretty cheap in the hospital compared to the high acute patients, right? But for the system as a whole, that's a crazy reason to keep people in the hospital.
So many of the people with medical conditions who are ending up being hospitalized are already long stay home care clients. We need to figure out, if we're going to come in with some post-acute services, how do we just better integrate the post-acute needs into those existing home care services and have some shared accountability for the home care to pick those people up and integrate them into their ongoing service conditions. We're asked whether they would like to participate, for example, in that pilot integrated funding model, and they had medical conditions and ongoing home care services. They were told they would have to give up their existing home care services in order to try the new model. And half of them said no. Mostly, actually, even more than half of the people who were already receiving home care said no, because they were afraid they would lose the relationships. So we have to figure out, there are some sticky things. Even people are afraid to give up bad service rather than have the risk of not getting any service at all. That's a bit of a fear, I think. And we've also seen, like, on the take up, depending on how things are presented to people should just be put into the new models and to see if they're actually better. In terms of the financial bit to hospitals, I would have had the exact same argument, and I think that plays very well up to sort of about 100% capacity in a hospital. That it is cheaper to have an ALC patient that is not costing additional procedures than it is to have a new patient that comes in, needs a workup, needs medical testing, needs procedures, needs a lot more activity. It doesn't make sense when you get to 130% occupancy, because hospitals are not funded for that additional, and they're actually in the red now. Many hospitals are behind on their budgets. They hope the government will just step in, which may or may not happen, or to what extent does it happen? And hospitals are actually, I think, suffering some pain, and certainly their workforce is getting very burned out by having vastly over occupied hospitals. And so I really think that we do need more opportunities for hospitals to enter that home care market. And I think with things like hospital at home programs, you're starting to see it. Like, they're just stepping in to solve their own problems and trying to do it sometimes within their own budgets, just because of the real challenges to their workforce.
So Walter, you've given a couple of international examples of integrated care. And a lot of our discussion so far has really focused on sort of a bundle of payment for a particular type of patient. And so it's not just hospital and home care. It's not just hospital and long-term care. It's primary care. It's mental health. It's social care. It's everything. And some of those models have been highly successful. Why don't we do that here?
So the biggest challenge, so even in all of the regional models that were implemented throughout Canada, to the best of my knowledge, I've not heard of one that included physicians or physician payment. So I would say that's a significant challenge. Physicians might only occupy about like 15, 18% of the budget, but they make 90% of the decisions. So they actually control access to an emergency department. It's a physician that says whether a patient will be admitted or not. It's a physician that says people need home care or not. It's a physician that says people should be applying for disability benefits. Like we have put physicians in a role of gatekeepers in Canada, where they are not part of the system is pretty crazy.
Right. So it's
So I
not true
really,
integration then, because
no.
it's
Yeah.
if it's a global budget, that would mean everybody, including physicians.
Uh, I think we can get there. We need to better support, particularly primary care, because they are the main gatekeepers. Office practices should be, well integrated into the system. There's different, I mean, there's a Dutch model of doing this where, they actually set up their own practices. They have a few models that they can do, but we could, offer physicians new models of care where their office expenses are actually covered. Because I'll say in primary care, paying your overhead these days is incredibly difficult. And so stepping in to directly support that, providing IT systems, government has been very reluctant in Canada to provide IT systems, which was just instituted in other countries to physicians. So we need to make some of those decisions. And the physicians in Canada have long had the view of having absolute clinical autonomy over their own decisions, and I just think we need to have that tempered with system accountability to
Right.
physicians. Because if the system's going to pay physicians, then they should have clinical autonomy. But for interactions with other parts of the health system, I think we need to have some accountability as to how physicians work with others, and frankly, they can be remunerated to it. BC has new models now for primary care physicians that provide for hourly basis so that they can do more coordination, teamwork, and build relationships outside of the community without only being paid for seeing the patient. And so we do
Right.
need to think about different models of care. We are largely stuck in Canada on a fee-for-service, and we don't want to throw out fee-for-service. We want physicians to be paid to see patients, but we need physicians to do other things than see patients, and they need support to do that.
Governance, administration, services, joint accountability. Why can't we get there? What do we need to do in Canada to fully integrate?
We have the system we have because it's suited the needs of the people who designed it. So providers have been very functional in creating the models of care. They've been mostly working fairly autonomously in the health system. We have institutions somewhat also working a little bit autonomously in the system. And we have policymakers who are trying to fit the pieces and deal with one of these groups at a time. That has created silos in the system. And we haven't actually come in with a policy of how are we actually addressing the population health needs. So I think we need a mindset change that we're not trying to just regulate physicians or hospitals or home care separately, that we're actually trying to deliver an integrated service for people. Then I think we need to spend a lot more time listening to the people, our citizens, the population. And they should be setting the priorities for what the healthcare system needs to look like to meet their needs. So I actually think to empower our citizenry is our greatest opportunity to advance integrated models of care because it's what they need. Quite sure that with political will, we could get there. The daily crisis on the front page often is driving policy and politics more than the fundamental issues. And so, this nice discussion we're having here is unfortunately not the discussion that's happening at the cabinet table on a regular basis. The cabinet table is much more worried about how are they going to put out a budget that people will like and feel that they can reelect the politicians because they've solved the daily crisis.
Last question. If you had a magic wand, what are the 3 things that you would do today to advance integration?
Thanks. What an opportunity. The first thing is we need to create safe space for new models of care. And we need to do that through experiments, and we need to be able to create waivers, legislatively create waivers that would allow healthcare providers to act outside of the usual rules. So they have these things in Medicaid in the United States called waiver programs, and that's where integrated models came from. The PACE model was built on a waiver because they were allowed to actually, within the confines, some guardrails, break some rules and do things differently. We need to allow experimentation in our healthcare system with a model of experiment, test, evaluate, and if it's successful, spread. Second thing we need to do is, in order for those models to be successful, and I've highlighted this a number of times, we need physician engagement. We need to have physicians in stewardship roles, in leadership roles. They need to be remunerated and rewarded for those roles. And I think we have a lot of physicians that will come in, and then we just need to make sure that we're building systems that support the needs of physicians, like not just we need you to do this for us, but what are some of the aches and pains that you have? Physicians have great challenges getting better access to the right specialists. Why is it up to every solo doc to need to know what the specialists are? We need core systems to allow to solving that problems, and then we'll have physicians more engaged in stewardship and receiving remuneration payment for doing that work. And the third thing is we actually need to measure and report and build accountability on what matters to patients as well as providers and policy. We have the reason that we only have anecdotal stories is because we don't collect data and report on patient experience across the health system. And we don't even actually report on most patient health outcomes across the health system. So we need to prioritize information so that we have that knowledge to best steer the system. For the most part, we're steering a system completely in the dark. And mostly what you'll see is how many visits people had to the healthcare system. And I don't think that's what we really want. What we want is how much health is the healthcare system producing. So those are the three things: experimentation through waivers, physician engagement, payment, and measurement reporting.
Thank you, Walter. We've got the start of a blueprint for policymakers to start to work towards better integration.
Thank you very much.